Hello, my name's Dr. Mary McCaffrey. I am a consultant gynecologist and I'm part of the network of consultants and doctors who work with UPMC Ireland. And I lead up the team with our UPMC Women's Health Clinic in Cork. Today, we're going to talk about health in the midlife and onwards. And an interesting fact is that if you look back into 2 decades ago, in 1850, the age of menopause was 46 and our life expectancy was 46. So women lived at a time when they almost died after their menopause. Nowadays, the average age of menopause is 51 years of age, and our life expectancy is somewhere between 82 and 85 years of age. So we spend approximately a third of our life in our postmenopausal years. And when you look at our next slide, I'm going to talk about the fact that it's important to make those years healthy years. And the foundations of our healthiness often starts in our early 20s, but it's never too late to start trying to get healthy and have a team of doctors and healthcare professionals who can help you with that. So now we're going to talk about the symptoms of menopause and perimenopause. And in this slide, we're looking at a long list of symptoms. But I think the first thing that is important to talk about is what the terminology menopause and perimenopause means. So the word menopause means that a woman has stopped her periods. And we use the phrase after a woman has had 12 months without any periods. But in the lead into the years of menopause, we now know that there are years called perimenopause, and this can go on for 10 to 8 to 10 years before a woman actually starts the menopause. And during those years, a woman may have subtle symptoms of menopause. She may have them intermittently during times of the month. They may come for a period of time and go for a long period of time. So they're quite variable and cyclical. And the sort of symptoms that we would see in the perimenopause, first of all, would be that periods would change. They can become heavier, they can become more irregular, they can become more spaced out. The biggest symptom that everyone knows about and thinks about is hot flushes and sweats. And we know that approximately 80% of women will get hot flushes and sweats during the perimenopause and as part of their menopause. Other women can get subtle joint pain, not just maybe a pain in a knee or a hip, but they can be generalized pains in small joints, in the neck, in different joints in the body. People talk about their energy levels varying and being quite low. This can be partly because maybe they're not sleeping so well, they're exhausted from the sweats at night. And obviously, another symptom people talk about a lot is memory issues. And this can be a worrying symptom for women because they worry that maybe it's the early signs of dementia, but most of the time it's nothing like that. Women are tired. We're part of a sandwich generation, looking after our jobs, looking after older relatives, looking after children. So it can be a really tiring time for people. And one of the first things that people can find is that they can't remember simple tasks, where they put something, someone's name, might take them a little while to figure it out. Mood issues are another symptom that are very commonly mentioned as part of the perimenopause and menopause. And we would see this as being a symptom that happens very much in perimenopausal women. They can become quite anxious, sometimes depressed. The women that are likely to suffer with these symptoms have often had maybe postnatal depression or anxiety in the past, a history of depression or anxiety in the past, or they may have what we call premenstrual mood changes. So mood can become very variable in the perimenopause. And part of the reason that it's more common in perimenopause than menopause is that our hormones can be incredibly erratic at this time of our lives. Palpitations can happen, and people often worry that this can be part of heart disease, when in fact it can actually be often part of anxiety and often a symptom of anxiety. When you talk to people, they can work that one out when you take them through their symptoms quite thoroughly. Insomnia and lack of sleep can be partly because of hot flushes and sweats. Anxiety, it can be maybe part of sleep apnea. And palpitations we've mentioned, and loss of sex drive and libido can also happen. And over time, then our connective tissue, our muscles, our bones, and our collagen can reduce in quantity, and that means that we have less strong bones, less strong muscles, particularly in the pelvic floor. That can be important, and this can be very linked with vaginal thinning. So the most important thing I want to zone in on today is about health issues. So while symptoms are very important, it's important for people to realize that health issues can be going on silently in the background without realizing it. The most important health issue we consider now as doctors when we see women who are older is heart disease and stroke, because this is the most likely thing that's going to affect your life, affect your quality of life, and be the highest risk for mortality. Then osteoporosis due to bone thinning is another health issue we need to be mindful of. Brain issues are important, and we know that also sexual problems and problems with the vagina and bladder are also important. So menopause and cardiovascular disease, a very important topic. So we know that heart disease presents differently in women, and we're going to look at that in more detail in another slide. But we know as well nowadays from a lot of recent research that having earlier life risks, early life traumas, we talk about adverse child events, that having incidents like that lead to a higher risk of heart disease and stroke later on in life. We know that having pregnancy-induced hypertension and preeclampsia also increase your risk of heart disease later on in life. So these are important groups of women that we're very keen to zone in on and help them with their healthiness. And remember, I said earlier, it's never too early to start. So if someone has had high blood pressure in pregnancy or preeclampsia, then straight after their pregnancy going forward into the future, they can look at healthiness and what they can do to protect themselves. And we know that one of the benefits for women who have a tendency towards heart disease or risk factors for heart disease is to be on HRT and to have it prescribed early. And we know that from previous Danish studies that you can reduce your heart risk much significantly, even as much as 50% if it started within 10 years of starting menopause. Obviously, we like to start HRT for cardiovascular protection before age 60 if possible. But women do come to us after age 60 who need HRT for a variety of reasons. And we'll always try and start on the lowest possible dose, because in the past it was thought that if you started HRT after 60 that you increased the risk of cardiovascular disease. But we now know that that's not actually true. There's a really good infographic in the next slide, and it shows us a little bit about the warning signs of heart attacks in women and how they are actually quite different to men. So women will often get subtle symptoms. It might be more like epigastric pain, heartburn, exhaustion, different kinds of symptoms. And there's a really good American website called Go Red. And we've put this at the end of this presentation for people to go in and research in. I think it's the biggest resource I've come across recently that will help people. So I've mentioned all the different things about heart health that we need to know, and I think they're very important. So the next important area to focus in on is our bones. We reach our peak bone mass in our 20s and 30s. And for some people who may have had illnesses in their 20s and 30s, such as maybe an eating disorder, or they may be celiac, or they may have different reasons for not being exposed to adequate vitamin D and calcium, those women may actually have a lower peak bone mass than even their peers in their 20s. So knowing that our peak bone mass happens in our 20s and 30s, this is important that we look at how we're going to maintain our bones going forward into the future, because osteoporosis is a silent disease. It's a very serious disease. We know that women who, for example, have a fractured hip, 60% never go back to full independent living. It affects lots of aspects of their lives, including their confidence. And I see this all the time with patients who maybe have a fractured hip, and they become really anxious about falling, really anxious about their balance, and just generally anxious in their lives. So it's important for us to protect ourselves from getting to that point. And anyone who has a fracture from falling from their own height, that's usually not a good sign. It's different if you fall off a roof or fall off a horse, but getting a fracture from a small fall like that means that you really should be focusing in looking at your bones, possibly having a DEXA scan, possibly looking at something called a FRAX score, FRAX, which you can do online to score your risks for osteoporosis, which might include having a family history of osteoporosis, having your own history of rheumatoid arthritis, different risk factors, low vitamin D, so important to look at. So in terms of bone health, we would recommend that most people need vitamin D because most of us in Ireland don't get enough exposure to it. We recommend resistance training because that builds muscles and muscles help to build our bones. We look at nutrition as well for women who come to us who might be at risk. And we encourage all people to be doing all of these things because they're important for the future. So nutrition, high protein diet, an adequate amount of protein, looking at your omega-3, 6 and 9 for your heart and your bones and your brain, looking at leafy vegetables for all the multivitamins. And then there are also medications that people can take if they have thinning bones. And as part of that, we know that if you're taking HRT, it does offer protection against osteoporosis as part of an overall medication package and lifestyle package. So then the other area that people worry about is brain function. And we know that HRT may reduce the risk of Alzheimer's and dementia. We wouldn't put someone on HRT just purely to prevent Alzheimer's or dementia, but we know that if people are on it, it can really help. But there are other risk factors for dementia as well that we know: social isolation, having hearing issues, having sight issues, being depressed. So all of those factors, when we meet someone in a consultation, we look at these things and encourage them to lead a healthy lifestyle for themselves. There's one small group of people that I would like to talk about, and we call it premature ovarian insufficiency, or POI for short. In the old days, it would have been referred to as premature menopause. They're a very small percentage of the population, probably only about 1% of women with menopause, but it can happen because people maybe had their ovaries removed early on in life. They might have had chemotherapy, radiotherapy, something that stopped their ovaries functioning. And we know that for those people, they're under 40 years of age, I need to say, that they're going to be exposed to lack of estrogen for longer. So all of the risk factors and health issues are likely to happen then for longer. And we know that HRT is very, very important for these people. And we know that HRT may reduce the risk of Parkinson's and dementia. The one area that people worry about when they think about menopause and think about hormones and HRT is breast cancer. And they worry about the risk of breast cancer because there was so much publicity about it at the beginning of the millennium. But we know now that the studies that produced that risk were actually quite flawed, and that they have been revisited, and that the risk of breast cancer is actually minute. Now, we would always, when we have people on HRT, review them after a number of years. We review everyone every year. I personally review all my patients every year. But at the 5-year mark, we would look at risks for breast cancer. We would make sure people are doing their breast examinations, having their mammograms. And the research is very clear that being on HRT really only increases the risks to 1 case per 1,000 people per year. So that risk is very small. It's much smaller than if you were a cigarette smoker, much smaller than alcohol intake, other lifestyle factors. But it's all about patient choice and about risking that. So while we would look at that in that scenario, we wouldn't usually prescribe HRT for people who've had breast cancer or who are at very high risk of breast cancer without talking to their oncologist. And there are so many other good alternatives nowadays. The one area that comes up quite a lot in consultations is that if someone's had breast cancer, one of the most worrying and annoying side effects for them can be the vaginal dryness and bladder discomfort that can go with vaginal dryness. And I think it's important for people to be aware that vaginal estrogen is actually safe for menopausal women who have breast cancer. And we always link in with their oncologist. We can use other things as well. But when you take vaginal estrogen, it's minimally absorbed into your body, so should be safe. So I've mentioned HRT, hormone replacement therapy, over and over. Well, will we talk now maybe about what is hormone replacement therapy? So when we talk about hormone replacement therapy, we're talking about replacing the estrogen that your body is no longer producing in adequate amounts. And that estrogen can be given by a tablet. It can be given through your skin, either through a patch, which you use twice a week, or as a gel or a spray, which is used every day. And that helps to replace the estrogen that your body is not producing naturally and physiologically anymore. But if you were to take estrogen in isolation on its own and you still have your womb present, then it can cause thickening of the lining of the womb, which is abnormal and which ultimately, for over a long number of years, could go on to become something sinister. So when we put people on estrogen for hormone replacement, we also give them something called a progestogen, which balances out those side effects of the estrogen and the impact on the lining of the womb. And that's usually given by an oral tablet, or we can also use the Mirena coil, which is a progestogen releasing coil that's placed in the womb. We can use that for progestogen also. And very occasionally, we give the progestogen as a vaginal medication. And depending on what your consultant or GP has decided, you'll be on a tailor-made regime for yourself. It's also important to be aware now that the government brought in free HRT for women from the beginning of this year. So any medications that you're getting in relation to menopause that are hormone replacement therapy are available to you with your drug payment scheme. So now that you know what HRT is, who and why do we prescribe HRT? So primarily we prescribe HRT for the control of menopause symptoms. And the symptom that it really controls most is the hot flushes and sweats. I've mentioned that it also can be part of your treatment for your bones, but we're primarily using it for hormonal control of hot flushes and sweats. And then when you're controlling your hot flushes and sweats, it may also then impact on your insomnia, which the hot flushes and sweats might have been causing. It'll help with your memory and all the other energy levels that go with that. And most particularly, can't mention often enough, women with premature menopause and the importance of them having access to their hormone replacement therapy. So when do we not prescribe HRT nowadays? And I would say nowadays it's actually very rare that we don't prescribe it. I've mentioned breast cancer. I think there'll come a time when we probably will be able for certain types of tumours to prescribe it, but at the moment we don't. Cancer of the lining of the womb and endometrial cancer, I have a question mark after that, because now in the States, they're starting for very low grade endometrial cancers to prescribe certain types of HRT. Women who have a high risk of blood clots may be at an increased risk if they're on HRT. Usually if they're on oral HRT, that would be the problem. So we would use, where possible, the transdermal types, the patch, the gel, the spray, in the lowest possible dose to control symptoms. And I would always link in with someone's hematologist, their blood specialist who looked after them for their blood clotting disorder, because they'll often add in a blood thinner to protect against that. So it's all about looking at quality of life and what can we do to help people. And obviously, if patients aren't keen on being on HRT, then we respect that choice and we look at what other alternatives are available for them. And there are lots of alternatives to HRT. The most important thing, and we look at this with everybody in every consultation that I do, we look at lifestyle changes, because we know, for example, that having a higher BMI will give you a greater preponderance to hot flushes and sweats. So looking at maybe weight management, exercise, having a low GI diet, a Mediterranean diet, all of those things can help with hot flushes and sweats. Looking at your clothing, what you might wear to work every day. Can you layer your clothing so that you have different layers that you can take on and off? Having a cool environment where you work, where you live, and particularly in your bedroom. And obviously bed clothing, bamboo sheets, different kind of cooling aids, everything like that can be very helpful. Then there are lots of hormone replacement therapy options. The most useful one that's come on the market recently is a medication called a kisspeptin, and the one that's licensed in Ireland is called Veosa. And kisspeptins purely work for hot flushes and sweats, so they won't help, for example, with exhaustion or whatever. But if the exhaustion and other are factors related to hot flushes and sweats, then that will be very useful. And we do need to take a very careful history to make sure there aren't other things going on like depression, burnout, things that would be managed very differently. And other medications that are available instead of HRT is an old medication called oxybutylene. We used to use it years ago for an overactive bladder. We still do sometimes, but that can be very useful for hot flushes and sweats and good to give at nighttime. Medication called gabapentin can be used. And then medications called SSRIs and SNRIs, people might know them as antidepressants, but in very low doses, which we wouldn't be using for depression, they can be very, very useful for hot flushes and sweats. And they'd often be the kind of medications we would use for certain breast cancer patients who can't take estrogen. And then, of course, there are talk therapies. And the NICE guidelines from the UK talked about this last year, about the benefits of CBT, for example, for managing menopause symptoms. And people were a little bit up in arms about it, not sure that they marketed the message very well, but it can be very useful in conjunction with HRT or for very particular symptoms such as insomnia. So they're all very useful alternatives that we can work with. And it's very rare that we would not be able to come up with a solution for someone with symptoms. So if someone comes to our clinic for a consultation, what would they be expecting to happen? The first thing we would always do is have a very detailed history. We go through menopause symptoms in a lot of detail. We look at family history in a lot of detail, because very often looking at the history of your family can be very important, particularly important for looking at cardiovascular and stroke risk, important for your osteoporosis risk. So we get a lot of information from that. And we do things like cardiac screening. We'd start off with the Q risk score and may follow that up with looking at certain blood tests, certain cardiac tests. And then we look at emotional health for every single one of our patients. We think this is actually really important. So we would screen for depression, for anxiety. And if there was any suggestion that maybe someone had burnout, that can be a useful screening tool as well. It's called the Sydney Questionnaire for Burnout. And then we give people information resources. We can suggest a treatment plan. Sometimes women come in very well informed and they've decided already what their treatment plan might be, and they might decide they want to start HRT that day. And if that's the appropriate line of action, then we'd be very happy to support that. It might be that we need them to look at lifestyle changes. And very often nowadays, we look at onward referrals to other consultants. And in the area of cardiology, that's really important, because we might want someone to have a more detailed cardiac screening. It might be to do calcium scoring, which can look at your risk going forward into the future. And more, there are more specialist things that we look at when we're looking at cardiology, because we know this is the most important area to zone in on as people get older, and making sure that people are managing their blood pressure and getting their blood pressure down to as low a level as possible. Rheumatology for people who maybe have rheumatoid arthritis, might have osteoporosis or osteopenia. They can be important areas to refer on to a rheumatologist. And it might be that the joint pain that people complain of, that we discover from our testing that they have some type of arthritis that needs to see a rheumatologist. And then lifestyle specialists such as nutritionists, might be someone to look at emotional health. They would be all areas that we very routinely get people to refer on to, and we can work as part of a multidisciplinary team with that. And that's an important part of, for me, of being part of the UPMC group, because we have all of these specialties at our fingertips somewhere. And a lot of the work can be done as part of a telemedicine consultation, or as part of, a one referral on to someone and then back to us for their follow-up. So they're all important areas to be aware of. And I'm going to give you some resources to look at because I think these are really, really important. So, after the take home messages from today, is that menopause is very important. It's very important that we look after ourselves for the rest of our lives. We're going to spend a significant part of our working lives in our menopause. We're going to spend a significant part of all of our lives in our menopause. And the resources that the first one is the menopause.org is the American Menopause Society. The next one is the International Menopause Society. And every time we do learning with either of these organizations and they put up videos and webinars for us, they match it every single time with something for our patients and for lay people, so that we know that when we do some learning, our patients will have access to learning it in a more simplistic form for them as well. Then the DAISY network is an excellent UK resource for women who've premature ovarian insufficiency. And the Osteoporosis Foundation, another excellent resource, and it has calcium calculators and all kinds of information on preventing osteoporosis, exercise, nutrition, whatever. And then lastly, this is my new favorite resource, goredforwomen.org/menopause. This is everything you need to know about heart health, blood pressure, because this is the one we want everyone to be aware of, because the knock on from all of the cardiac issues are the issues for your brain health, etc. So they're areas that you'll be able to, over days after listening to us, go in and research and see what you'd like to do. And as part of our network in Ireland, we have, as I said, a lot of hospitals, we have a lot of specialists, we have access to a huge amount of areas such as Santry Sports Clinic, rheumatologists, orthopedics, every area that helps us to look after the women who are coming to our clinics. So thank you for taking time to listen to us tonight.